Good afternoon. I'm Richard Tannen, and what I want to address with you are, based on the work we've done, what we believe are the requirements for a database that will yield valid answers to healthcare questions. We began this work more than a decade ago, and we started out with a very simple strategy. The strategy was to determine whether an electronic health record database could provide for valid outcomes or effectiveness research. Okay? Now, nobody really had rigorously tested that question. If you can't prove that a database can really yield valid answers, then it's worthless. So, and to produce valid answers, it's how the database is structured, how good the information in it is, and are the analytics sufficient to get answers that are reliable. At that time, the only real database that was available that had the potential to do that was the United Kingdom General Practice Research Database. One of the reasons for that is the way the healthcare system is organized in the United Kingdom permits you to do things in terms of making a database that would be very difficult to do in most other countries. Our research was initially supported by a grant from the National Institutes of Health, and currently is being supported by a grant from PCORI. And what did we do? We did something that's very simple, a little complicated to do, but very simple. And we said, how can we test this? And what we did is we decided we would try to replicate randomized controlled trials that had previously been done and were well accepted. And what we did is we used the database and we replicated the characteristics of the people that were in the treated group in the randomized controlled trial and the same characteristics in the untreated group. And we did everything the same, except we didn't have randomization. Now, the key is randomization makes randomized controlled trials work because the treated and the untreated groups have all the same characteristics, and it's a flip of the coin as to who gets in what, but in the aggregate, they all are the same. And then we will test it whether or not the database gave valid answers, which would depend on the quality of the data in the database and the analytics that we used to examine the data that you collected. So we then said if the database answers were the same as the randomized controlled trial, then you could say you were getting a valid answer. If they were different, then you weren't getting a valid answer. Could be due to not so good data in the database, but it also could be due to something that's called unrecognized confounding or bias. That is that when you did a database study, the people who ended up being in the treated group in the real world and those that ended up being in the untreated group had different characteristics that we didn't recognize were important and were different. If you look at this slide, and I must say I have trouble seeing it from here, but this was a series of randomized controlled trials that we did. And we looked at 3 different outcomes because of the nature of the database, and we thought we could get reliable answers for those outcomes. On the far left side are myocardial infarction, acute myocardial infarctions. In the middle is the combination of coronary bypass surgery and or percutaneous transluminal coronary angiography. And on the right, stroke. And if you notice, there's a central bar down each one of those. If the answer is on the left, it means the treatment that was done in that particular randomized controlled trial limited the amount, for example, of heart attack, if we look at the left side of the slide. If the bar is on the right, then it didn't limit it, and it might even have made it worse. Okay? Now, if you look at the answers, the dark dots and the bars around them, which are their, quotes, confidence intervals, are from the randomized controlled trial study. The pink ones are from the database study, done exactly the same as the randomized controlled trial. And what you'll notice very quickly is in some of these trials, the pink ones and the dark ones are going in the opposite direction. And what that means is you have unrecognized bias, or what we call unmeasured confounding. Now, in the aggregate, in 6 cases, the randomized controlled trial and the database study, which I've called GPRD, were the same, or at least not significantly different. On the right side, there were 8 where the randomized control and the database study, GPRD, were significantly different than one another. So that's a big problem if you're going to be looking at database information and you're going to try to draw conclusions from it. And you don't know why the answers are different. And that's a big problem. It's not so bad that the answers are different. You don't even have a clue why they're different. Now, it turned out, because we did these studies, and no one else ever had done any studies like this, nor have they done any since, we had this information of what answers were right and what answers were wrong. And we said, is there a way of figuring out how we can do analyses that overcome this problem of bias? Because if you couldn't do that, this whole idea of a learning health system and a database is worthless. You're not going to get reliable answers. So here's the answers that we got using a very simple, quite frankly, analytical statistical technique that we tried out. And if you look at these sets of data, you'll notice now that there are very few instances where the blue bar, which is the data analyzed with the new analytic technique, and the dark bars, the one from the randomized controlled trial, are different. In fact, virtually not 100%, but in the vast majority of them, this statistical technique, a very simple one, which I'm not going to try to go through at this stage, but this technique demonstrates that it wasn't the problem with data in the database that was incorrect. It's the problem with the analytics that impede doing this in a way where it could be meaningful in the long term. Now, this is just a summary of what we call the PERR. It stands for prior event rate ratio. That's because that's the way we did the correction. And you'll notice that the GPRD, that is the database, PERR corrected compared to the RCT were the same in 11 out of 14. 3 out of 14 were not, but they were always much closer to one another than the non-corrected data were. Now, what are the features of the UK database that are probably critical for making this happen? Not only did you need the analytics we developed, which as I said are very simple, they may not work, this analytic may not work for every outcome, it probably won't, but I don't know of anything that's been reliably shown to work effectively for unmeasured confounding or bias other than this strategy. The rest of the stuff that's out there, in my judgment, is not particularly useful. And it's never been rigorously proved, despite a lot being written about some of it. So this is the size of the UK database that we studied. It's approximately 10 million patient records. We thought that was gigantic when we started doing this. As it turns out, we figured you need to really make this thing work in all the ways it could. You probably need 50+ million patients. So that's a lot of patient records. It was a representative sample of the population of the United Kingdom. That's also important. If you're going to tell people in the United States it works, you can't say it works in Georgia and it doesn't work in Alaska. You're going to have to be able to say it works on people everywhere. The other thing is that in the United Kingdom, a patient's record is centralized in their general practitioner's records. That is, one, there's a health system where everybody has to have a general practitioner, and two, if the patient gets seen by a doctor outside of the general practice, a consultant, or gets seen in the hospital, they are obligated to send that information to the general practitioner to put in their record. So it has all the important healthcare events. It also is structured so that it's a complete longitudinal record of care. That is, you know when the patient started being seen in this general practice, and you know when they stopped being seen. They may move, and then they stop being seen, or they may die, and then they exit it. And you need to know that if you're going to do these analyses and have them get proper answers. And finally, one of the critical things that exists in this database is when you order medications in the UK, it gets done electronically and it goes to the national health system. So you know virtually every medication that any of these patients are taking. And that's another critical element, because if you're going to study if drug A is any good to treat this, you need to know what other drugs people are getting. Now, there are limitations to the UK GPRD. It's not perfect. One, at the time we started studying it, it wasn't linked to a laboratory database, so that if you were trying to study outcomes or effects that require laboratory data in order to get good answers, you couldn't get it. That's why we studied heart attack, stroke, and which didn't require that. You don't need any laboratory data to know if someone's had a heart attack. And as I said initially, ideally size we project from the work we did would be 50 million. Remember, this was a pilot study. This was to see if a properly constructed database with proper analytics could yield reliable answers. But it's not big enough to do a lot of stuff. It's really not. So this is a proof of principle study, which says a properly constructed, large learning care health system, and I would let's say it has to be structured as a database, or at least a component of it does, can yield answers that are valid for outcomes research. And if we're going to do it elsewhere other than the United Kingdom, it's going to need to require virtually all of the components that exist in the United Kingdom database. And in my own humble judgment, I think if this is done, and it's done right, and it's done well, and ideally done as fast as possible, it could transform healthcare. It will mean that we will have answers to multiple things we currently don't have answers to. You can't get all the answers from randomized controlled trials. Randomized controlled trials, one, are in truth only limited to the people that meet the characteristics of people that were put in the randomized controlled trial. If you had this kind of potential, you could study people of different ages, people with combinations of diseases, et cetera, and get reliable answers. You can only do that with a large database. And what are the future challenges? Well, I think there are two, maybe more. One is to develop that kind of database in this country and make it that big and prove that it works. And two, there needs to be new methodology also developed to deal with the overcoming of bias. I don't think our methodology is the only one. I don't think it's going to be the last one. But there needs to be a real push. Get creative people to develop new methodologies, and they need to prove that those methodologies work. They just can't say, oh, my guts think it works. That is not going to work. You're not going to treat people based on somebody's guts. You're going to treat them based on